Kei aka nui, kei aka rahi, tēnā koutou. E mihi ana nā kai kōrero o te kaupapa. E mihi ana ki te kaupapa. E mihi nui ki te whataora Waikato mō tō rātou tautoko. He mihi nui hoki ki te tainui me te kuini nā waihono o te papau mō te rātou manaakitanga. Ko wai au, no a whereka ki te tonga oku mātua, I tipu aki ahau ki Johannesburg, kei manakau ahau e noho ana, he manakura ahau ki Waipapa taumata rau I te māturanga haora, he Pākehā ahau, ko Warwick Bag taku ingoa, tēnā koutou, tēnā tātou katoa. Welcome everybody, my name is Warwick Bag. I'm the Dean of the Faculty of Medical and Health Sciences at the University of Auckland. And it's my great pleasure to be here at the University of Auckland Waikato Clinical Campus. This is an auspicious occasion in which we've come to honour Martin, who has been made a Professor of the University of Auckland Waipapa taumata rau. For those of you who are not familiar with the process of becoming Professor, it is an inordinately challenging task. And Martin was particularly well prepared in preparing for that task. He contacted me well in advance of the date of submitting his application, which required a small forest to be cut down for all of the paperwork that was required to prove that he had met excellence in research, teaching, and being a good academic citizen. Martin is an esteemed cardiologist and clinician who is well known to many of you, and it was a pleasure to meet some of his patients who are here tonight. So welcome to them. Martin's going to share with us what he has achieved to join the professoriate, and we welcome Martin to being part of the professoriate. It's also an opportunity for me to thank colleagues here at the Waikato Clinical Campus of the University of Auckland. Some of those inaugural colleagues are sitting in the back row because they didn't want to sit in the front row. But Peter Rothwell and Raywin, who started the campus, are in the back and they're putting their heads down right now. But I want to really acknowledge them for what they have done. You don't get to appoint professors unless you have people like Peter and Raywin who start the fire and then make sure that it is lit and continued on. Raywin has been here 30 years. She tells me that our inaugural cohort was in 1994 of 24 year 6 students. Prior to that we'd only had students coming from time to time, but from 1994 we had them here for the full year. We've now got a cohort of over 170 students who are currently based here at the Waikato Clinical Campus, spread throughout the middle of the Waikato. In fact, our rohe extends from Taranaki to Whakatane and up to Kaitaia and everywhere in between. And we are very proud of our relationship with the Waikato Te Whataora. This is a celebration for Martin. I welcome his wife Rachel and children and his parents Roger and Joan. This is a time to see what your dad's done with all those after hours time. And he promises that he'll spend more time with the family afterwards. No, he didn't say that. What's going to happen tonight is that Professor Julian Payton is going to formally introduce Martin. Martin will then give his short lecture. Professor Prash Sanders, who has come from Austria via Melbourne to be here just on time, will then give concluding comments, so welcome. And then I will have some concluding remarks, after which the final bit will be for us to socialise and spend some time together. Thank you all for coming. Welcome to Professor Martin Stiles' inaugural lecture. I'm now going to hand over to Professor Julian Payton.
No mai, haere mai. Welcome to you all. It's a great pleasure and honour and privilege to be able to introduce a fabulous colleague such as Martin tonight. And thank you for this opportunity. I'm going to start off with a brief introduction for myself and then, of course, introduce our speaker. So, tēnā koutou katoa. Ko Quantock Hills, Somerset, England, Te Moanga. Ko Willicombe Bay, Te Awa. Ko Pakeha, Te Iwi. Ko Ngāti Whātau Ora Kei, Te Iwi a Te Aki, ora I e aho. Ko Julian Payton toku ingoa, ngā mihi nui kia koutou. So I'm Julian Payton. I'm a professor of translational physiology at the University of Auckland. And I'm also the director of the Heart Research Centre at the University of Auckland. And I co-direct Putahi Manawa, which is the Centre of Research Excellence for Heart Health Equity. And Martin, of course, has been a founder member of both those centres, and his support has been fantastic. Now, before introducing Martin, I'd like to briefly welcome his family. There are many of them with us tonight, which is fabulous. First, of course, and most important, because she cooks your dinners, she tells me, is his wonderful wife, Rachel. Their children are here tonight, Liam, Brooke, Kate, and there is Isabel, who is not here, but she is in Wellington, I understand. His siblings are also here, Clark and Carol, and has Diana in Geneva. There's also, of course, good friend and colleague here, and a very special welcome again to Professor Prash Sanders from the University of Adelaide and Royal Adelaide Hospital. There is also some apologies, including Professor John Skinner, Dr. Nigel Lever, Dr. Andrew Martin, Dr. James Fisher, Professor Joanna Montgomery, Professor Bruce Smale, and Soteria Eremia. Now, I'd like to introduce Martin. Today, we celebrate Martin becoming formally a professor of the University of Auckland. And what does being a professor mean? Well, it is the highest rank possible within the hierarchical organisation of a university. And somebody that is a professor, as Warwick was saying, has to demonstrate significant achievement and expertise, and also have made outstanding contributions to knowledge and has been acknowledged both nationally and globally as somebody that's made a huge difference, whether in research, teaching and of course his clinical work. And as I will show you and demonstrate, Martin has gone beyond that in my mind. I think he should have been promoted to professor many years ago with all that he's done. However, it is only till today that Martin is going to be formally made a professor, and we congratulate you, and we are all here to celebrate with you. So, looking at Martin's CV, and sometimes these introductions can be a bit dry, and this one will not disappoint those that like dryness. But there will be a little bit in it for everyone. So just bear with me as we go through a bit of a drought before we hit the big rainstorm at the end. So on his CV, he has all these abbreviations. And what on earth do they all mean? This is what they mean. Very, very impressive, as you can all read. I'm not going to read them out. But I think what I would conclude here is that he's a jolly good fellow. Of course, what it means is that he has made a significant contribution. He has demonstrated excellence, both nationally and globally. A little bit of where Martin has worked and what he has done. So, started off here, and he ended up back here. And let me tell you, that doesn't always happen to Kiwis. They don't always come back. Martin has, to the benefit of Aotearoa New Zealand. You can read again, House Officer here, then to Edinburgh, and incidentally, my father guarded that castle during World War II. Then to Leicester, that well-known city, and then of course to Adelaide, where he met Prash. Following that, he did a PhD there, and notice the time at which it took him to do a PhD, whilst also doing clinical work. Only 3 years. Outstanding achievement and an accomplishment to have achieved a PhD in 3 years while also working. Then to Green Lane, very famous cardiovascular unit there. And then 2000 till present, he now is Director of Electrophysiology here. He's the chair of the New Zealand division of the Cardiac Society of Australia and New Zealand, and of course, Professor of Medicine, University of Auckland. Fantastic achievement. This is where things get a little bit drier, but it's just important because what he's achieved is phenomenal. Over 124 publications, I think 125. And importantly, 44% of them are in the top 25 most cited journals in the world. Extraordinary quality. Over 9,764 citations, which means that his work has been cited that many times by other researchers around the world. His H-index is 36, and all that means is that the number of citations of each paper is around 36 times, which I can assure you is phenomenal. He's given over 40 invited presentations at meetings around the world within the last 5 years, again demonstrating he is a world-class clinical scientist, and 15 prizes to date. Just some personal reflections as a friend and a colleague. I could not ask for a better clinical academic colleague than Martin Stiles. He never says no. He's always receptive to helping us as academics. He helps with our grants, with our papers, and with our studies, including first into human studies. He is a hugely respected and cherished colleague. I know that because I've been down here and I have seen the interaction. He is loved, adored by people in this hospital. He is so extremely well networked, both locally and around the world, and he's always at the end of a text. Almost a knee-jerk response is what you get from Martin. He is an outstanding doctor, and for me, and I've seen this firsthand, he's a doctor that genuinely cares about his patients. And I mean genuinely cares about his patients, and all credit to him. He was also the first person to call me a Jaffa when I arrived off the aeroplane back in 2017, and not knowing what a Jaffa was, I had to ask him. I'm not going to tell you what it means, but I can tell you I've never been called a Jaffa again, Martin. Having gone to a number of meetings with him, I've noticed that he does like to dance and perhaps sing occasionally. And that made me do a little bit more research about Martin. Who is this person? Because it's always nice to know personalities and what people might do in their spare time. So Martin on the left, you'd think he's on holiday. Well, he was, but then he decided to do some work because he is a workaholic. He loves cricket, and he loves Whangamata as a holiday destination, and that's beautiful. But there's something else we also know, and that is that he loves to dress up. And you can see, whether it's Superman or a turtle or a goat, it doesn't matter. But I think the thing that got me the most was combining the dressing up with the singing, and unfortunately I can't play the video, but I can show you a picture of Martin being one of the Spice Girls. And here he is. So without further ado, if you hadn't noticed, he's second from right. And great legs, Martin. I'm going to hand over to you now for the main act. So thank you very much indeed, and welcome.
Thanks very much, Julian, showing an excellent grasp of the screen grab. Yeah, the internet never lies, it's always there. Thanks everybody for coming. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Martin Stiles aho, no Ngāi Tahu aho, ko Porongia te Maunga, ko Waikato te Awa, ko Kirikiri Roa te Kāinga, ko Martin Stiles taka wingawa, nau mai, haere mai. I thought I'd start my talk with this video of the upper chambers of the heart showing the electrical activity in an arrhythmia that until the last 10 or 15 years we couldn't treat. But now with the technological advances that we have and the research that's been done, we can treat this sort of arrhythmia. My name's Martin Stiles from the University of Auckland, and this is my picture. So, how to prepare for an inaugural lecture? There's a wide audience, as you can see. I have everything from school friends, to family, to patients, to colleagues, to professors. And it lends itself to a timeline, and then I did this, and then I went here, and this is what happened. I'm trying to avoid that and sort of delve into things as they appeared. But I thought one of the things was, how does one do research from New Zealand and show it to the world? And many of you are thinking, well, what does a professor do anyway? And I think the public perception of a professor is perhaps absent-minded, possibly nutty, maybe even murderous. But this is the professor that I sort of think of, I would more closely identify with. So what does this professor do? Well, this professor does half-time clinical work at Waikato Hospital, 2/10 clinical work in private practice, 3/10 for the university, of which roughly 40% is research, 40% is teaching, and 20% is service leadership, or what the university titles eminence. And there are different types of researchers. So there are basic science researchers who work on, DNA, proteins, work with animal models, that sort of stuff. There's a little bit of that in what I do. I do some clinical trial work where I take new therapies and trial them in a clinical setting. But I guess how I describe myself as a researcher is a collaborator. And that's kind of working with other people to bring things together and hopefully get some result. This is how it started. My parents, Joan and Roger, are here. Joan, thanks for keeping this. So at 7:25 in the evening on the 12th of May 1972, I was born in the Campbell Johnson Hospital, where I was just like a few hours ago. And this is the first record of my surname being misspelt. And it's happened a few times since, with an I, if you're wondering. Yeah, and then a few years passed, and I left Hillcrest High with this leaving certificate. And this was in 1989, and you can see I left with calculus, statistics, chemistry, physics, and music. And you're thinking, well, how does somebody who does medicine not do biology since the last part of their school? Well, the idea was for maybe to do engineering, but this friend of mine, Carl Horsley, said, well, look, this is him in a Hillcrest High jumper. Carl saying, well, I'm thinking of doing a medical intermediate at Waikato University, which you could do at that stage. Maybe we should do that, and if that doesn't work out, do a BSc or whatever, but it sounds like fun. And I said, okay, I'm up for it. So this is a map of southeastern Hamilton, where much of my life has played out. So this is where we are now at the hospital. This is where I grew up, in Balfour Crescent. This is my primary school, this is my intermediate school, this is my high school, and this is my first year of university. And now we are back in Waikato Hospital, and I've been back here since 2008. I have been some other places, as Julian pointed out, so we'll go through those. But this is pretty much where it all happens. So back in the day, you could do a medical intermediate for Otago, outside of Otago. And so I did mine at the University of Otago, at the University of Waikato. And you had to do 8 subjects, 5 of them core, 2 chemistry and 3 biology, including a second year paper, which was challenging for someone who hadn't done biology since 5th form science. And we had to do 3 elective subjects, English, politics and calculus. But the calculus tests were at 7 in the morning, and there was one 4 weeks into the course, and I scored 62%. And I thought, this is no good. So Carl was doing social and moral philosophy and getting A+ for 500-word essays due every Friday. So I quickly switched over to that, and that was what happened. So you had to pass all of these, but you competed on your top 6. And the competition was interesting because at Waikato, the marks, the grades, were 5% cheaper in marks than at Otago. So, yes. So to get an A at Otago, you had to get 85. To get an A at Waikato, just 80. So this is the first of a series of administrative errors that have led me to where I have become today. Then went off to Otago University, lived in the Ferguson building. Many of us have been there, trained there. Some of you in my class are in this room. This was me at Carrington Hall, I think operating on my teddy bear, and you know, seemingly innocent, and then Spates. And so, as happens to many of us, I joined a band. These are my 4 mates in the band, Rich, Ryan and Jim, and this was a lot of my university time. So travelling around the lower South Island, playing places like Invercargill. This in fact is the Northern Tavern, I think, in Invercargill, Alexandra, you know, Cromwell, those sort of places. And that was great fun, spending weekends playing in the band. I tried to distill medical school in one slide: 2 years of preclinical, class of 180, 3 years of clinical, class of 60 in Dunedin. Many, as I say, are here. Where are you, Nicola? You? Yeah, professor. There you go, professor of medicine. My boss. It was in Dunedin, and then, as now, you get an elective study period, and this was 12 weeks. So I spent 6 weeks at the emergency medicine department in the Royal Infirmary of Edinburgh, and I haven't shown you a photo of the hospital. I've shown you a photo of the pub. And this pub is across the road from the Old Royal, and when I was there, actually had a phone connected to the switchboard of the hospital, which tells you a little bit about the relationship of the pub and the hospital. Then a little bit of a tripping around, and then headed up at Guildford Hospital in Surrey, where I did general medicine for a time. But eventually, Carl and I, who started together in Waikato, ended up graduating with our degree in Dunedin. And then I did a year of house officer in Dunedin. I don't remember much about my house officer here in Dunedin, except that I broke the 144-hour per fortnight rule and got 2 penalty payments in that year. And so it was really hard work, but finished that and came back to Hamilton and did house officer for a year here, and then a registrar basic trainee for 2 years, and then into advanced training as a registrar. And I only did 6 months of general medicine in my cardiology training, which I think must be some sort of record, which I'm quite proud of, and managed to get through. So some of you are thinking, well, how do you become a cardiologist? Well, 2 years minimum as a house officer, 2 years minimum as a registrar, sit and pass, more on that later, the Royal Australasian College of Physician exams. And then you do 3 years as a cardiology registrar, complete the requirements for the college. And when I did it, 2 years in Australia and New Zealand, and then 1 year elsewhere. These days, I think you've got to do all your years in Australasia. However, having passed the written in March of 1999, I failed the practical in June of 1999 when I went to Auckland. So that was a bit of a setback. Not only was it a setback, the next exam is a full year away. Moreover, if you failed that, and when I was doing it, if you failed that a second time, you had to resit the written, which I wasn't particularly keen on doing. But fortunately, in Dunedin the following year, I sat and passed that exam. So that was a bit of a hurdle. Did my 2 years here, and then decided to do my 3rd year of college training in the Royal Infirmary of Edinburgh, where I had been before. And I worked at the Old Royal, and I lived across the Meadows, a big park in Edinburgh called the Meadows, and the Old Royal was across the Meadows from my house. And we used to do on-call in the weekends, and we had to do echocardiograms in the weekends when needed. And generally, you get called out in the middle of the night because someone had got stabbed and in the chest, and you had to see if they had been stabbed in the heart and what was going on. And so I remember one day walking across the Meadows at 2 in the morning to scan a guy, and I said, look, where were you when he got stabbed? And he said, I was in the Meadows. So after that, I took a taxi, which is considerably further, but possibly safer. And an interesting experience when I was there, we moved out to the Little France, to a new Royal, brand new hospital. That was a real experience, a long way from the 5 pubs that were across the road. In fact, the pub close to the New Royal, you didn't want to go into unless you really did want to get stabbed. So I then went to Leicester, Glenfield Hospital, and when I arrived in Glenfield, there was, as a clinical fellow, there was a new technique called biventricular pacing, which was a novel pacing technique, and so novel that it got profiled in the Leicester Mercury. And it's really dramatic. If you read the text in this, the man who died twice, he died twice because we put him into ventricular fibrillation on 2 occasions and got him out because we wanted to test that the thing we put into work. But anyway, the reporter said, "There we go," says a satisfied Dr. Stiles, just like peeling an orange. What I was trying to describe is trying to get into the tissue plane to make the pocket for the pacemaker, but I got teased about that for the remainder of my time for Adelaide. I was probably quite pleased to leave. Something that I probably don't keep a little bit quiet is my time during there, I did about 150 angioplasties. My plan at the time was to be a sort of an angioplasty pacing doctor. But I became gradually interested in electrophysiology in my time both in Edinburgh and in Leicester. Also have had a bit of a grounding here from Hugh McAllister and Spencer Heald. So I just want to take a break for a moment and think, well, how electrophysiologists see themselves. They see themselves as, I don't know, somewhat studious, liking to explain things to other people, having people think things through. How do other people see EP? They think it's wizardry. So I agree, but fear not, for I believe even this foul beast can be ablated. I quite like the idea of other people in the department not really knowing what I do, and so I can make up extraordinary things and they carry them out. So I returned to Auckland Hospital in New Zealand, Auckland Hospital in 2004, a fellow of the Royal Australian College of Physicians, but not as a consultant, as a registrar. And there was less responsibility in Auckland than I was being used to given in the UK, not doing my own cases. And frustratingly, there was a 3D mapping system in the corridor, but we couldn't use it because the business case for the consumables has not been passed. So, sound familiar? So I thought maybe I should train properly in electrophysiology. And I looked around and I found this guy who's sitting down here. Who incidentally has just arrived from Vienna via Melbourne at, 5:28 to get here in time. And I can't live like this. Anyway, and so he was in Bordeaux, at a centre of excellence in Bordeaux, and had been appointed as professor to the to Adelaide University. And he was looking for a fellow, and I was looking for a fellowship. So I guess we probably took a gamble on each other. I was his first fellow, he was my first professor, and I think that his gamble was greater than mine. But I went to Adelaide and enrolled in a PhD there. And my PhD was on clinical research, and I did research during electrophysiology studies. So these are patients with atrial fibrillation and with atrial flutter, and we compared those patients, what the data we collected at EP study, and compared to those, the reference group, if you like, for having EP studies with no other reason. So some of you are thinking, well, what's atrial fibrillation? This is a heart in normal sinus rhythm. You can see here the top chambers and the bottom chambers are contracting in a coordinated fashion, and it's pretty even. This is atrial fibrillation. The top chambers are kind of quivering. The bottom chambers are going rapidly and fast. And so AF contributes to stroke, heart failure and hospitalisations, and this is what we're trying to achieve. What do patients feel? Well, they can feel a number of symptoms. Importantly, some patients actually feel nothing, which is a problem in itself because sometimes they run into real trouble from the consequences of atrial fibrillation, having not known they've been having it for months or weeks. Perhaps check on the orange and black slides. This is the old PhD slides. So this was one of the chapters of my PhD. The PhD thesis is somewhere in the audience. Oh, there it is. There you go. Took it for an outing. Doesn't get out much. What we knew then was that if you took an animal and repetitively induced atrial fibrillation in the animal, it became increasingly excitable. So the first time it was hard to put them in AF, but subsequent times it became easier and easier to induce atrial fibrillation. And the phrase AF begets AF was coined. And so we felt, well, if we maybe could get people out of atrial fibrillation quickly, then they'd stay in sinus rhythm more readily. But in fact, that strategy of getting people in and shocking them back to sinus rhythm didn't really work. So that although AF begets AF, sinus rhythm does not beget sinus rhythm. So we thought there must be a second factor that predisposes patients to get atrial fibrillation. So we hypothesised there's a pre-existing abnormal atrial substrate in patients with paroxysmal low atrial fibrillation. Importantly, we chose to study this remote from recent arrhythmia. So this is what we did. This is an X-ray here of the catheters that we put in the heart. I think there's 5 catheters in various places. We looked at the excitability of the atrial tissue at these 10 spots. We looked at the conduction time along the bottom of the left atria, up the side of the right atria, and along the roof. We looked at sinus node recovery time by pacing the heart for a bit, stopping, and just seeing how long it took for the heart's own pacemaker to kick in. We looked at these things called site-specific conduction abnormalities, and we made these electroanatomical maps. So see this map here, we're very proud of this nearly 200-point map that we made at the time, and some people are laughing, yeah, thank you. Very proud of this 200-point map, we looked at the voltage, we looked at the conduction, and the electrograms, in particular these things called fractionated signals, which are the pink dots, and double potentials, which happen to be the blue dots. What did we find? We found that atrial excitability was less in the patients with atrial fibrillation than the reference group. This is the effective refractory period, it's higher, it's inverse. So we found something different than what was found before. We found that conduction time was longer in the AF patients. We found sinus node function was impaired in the AF patients. And these were our electroanatomical maps. So just to guide you here, the top two maps are examples of the reference group, the bottom two maps are examples of the AF group. There's a little bar here that tells you the voltage. Blue and purple is high voltage, red and yellow is low voltage. So you can see that the ones at the top are more blue and purple than the ones at the bottom, which are more red and yellow. So there's a lower voltage in the AF patients. Furthermore, the volume of these chambers is higher in the atrial fibrillation group than in the reference group. These things called fractionated signals and double potentials, 27% in the AF group versus 8% in the reference group. Is AF not due to high blood pressure, heart failure, you know, that sort of stuff, is associated with abnormal atrial substrate. There are structural abnormalities, there are conduction abnormalities, there's sinus node dysfunction, and there's a reduction in the atrial excitability, contrary to the animal model that was the model before this. So we thought this was really interesting work, and the people at the Journal of American College of Cardiology agreed with us and published it for us. And this has been shown in multiple studies across many diseases: aging, hypertension, heart failure, sleep apnea, and obesity. So this is sort of now the sort of accepted state of things in atrial substrate. What do I do now in atrial substrate? I work with the Auckland Bioengineering Institute, 4 of whom are sitting in the back row. Zhao Zhao leads that group, and there's different levels of remodeling. So there's remodeling down at the cellular levels. These proteins called connexin 40, connexin 43, they're down regulated. There's tissue fibrosis. You can see increasing amount of fibrosis, the more persistent the atrial fibrillation comes. Organ level, the left atrium dilates. And this fibrosis is this addition of collagen in between cells. This interferes with the normal electrical conduction, and there's increased space between these cells, and this makes the patients prone to arrhythmia. We've taken MRI images of patients that are about to have AF ablations, and we've looked at their echoes and their voltage maps. So I take these voltage maps at the time of the procedure, and we use the scarring, the red parts, and we correlate it to the scarring that we can see. And we've taken a number of Waikato Hospital patients. CHL, we got another one on Tuesday for you, and I hope you've seen Rebecca because you download it to a USB stick. And all these patients went on LG MRI and the voltage mapping, and this data is analysed, correlated with each other, and segmented out, and we're learning a lot about how we might approach someone's ablation even before we start because we've done the scan. So my research into AF substrate starts in 2005 to 2008 in Adelaide and continues now with the Auckland University. So then I returned to Waikato Hospital for about 7 years away to commence an AF ablation program. I just remember Danny Checkett said to me, I said, I'm back to live in Hamilton. She goes, no, you're going back to die in Hamilton. There's a large folder of referrals waiting for me. And I couldn't do the ablations until we got the essential equipment purchased. I still remember walking down North Terrace, getting a phone from Max Lynn saying, Martin, your 3D mapping system's here. I said, great, Max, I'm booking my flights. This is an ablation. This is a number of catheters coming up from the groin or down from the neck. And you can see this catheter here has gone across and into the left atrium and is burning around what we call the pulmonary vein. So it's going to come up again. It's going to come up from the groin, through the interatrial septum, into the left atrium, and then makes a series of scars around the mouth of this vein so that the electrical conduction doesn't go from the vein into the heart, because the veins are the things that cause the mischief here. So the early AF ablation program we did, starting with Irene, I see there in the audience, 7 ablations before Christmas 2008 and a few in early 2009. And then we planned 7 ablations in the last week of March 2009. And Prash came over to help me with these 7 ablations, 2 on Monday, 2 on Tuesday, 2 on Wednesday, and 1 on Thursday morning. The one on Wednesday afternoon is sitting down there, Weibo Veldman. And Weibo... Weibo, some of you may know, won a gold medal at the 1972 Munich Olympics in the rowing 8. And so until then, Prash and I had only done one silver medalist, Raylene Boyle, in Australia at Adelaide, and so I one up on Prash and said, well, here's a gold medalist. And not only that, the one on Thursday morning was Rob Waddell. And so two golds to your silver. So Rob just texted me literally like 2 hours ago to say that he was going to come, but Sonia has torn her hamstring off the bone, competing in the St. Peter's Parents Relay. Which I think is classic athlete behaviour. So just never give up. So look, this got quite a lot of media attention, and it was in the media at the time. So we've moved now from radiofrequency ablation, which we started out. I learnt it with Prash in Adelaide. In about 2012, we started doing cryoablation. This is freezing the veins rather than burning the veins. And then the last year or so, we've moved to another one called pulse field ablation. This is a non-thermal ablation, neither hot nor cold, passing electrical field over the cells and causing scar in that direction. So for my research up until this point, I won the Medical Scientist Award at the Waikato Kudos Awards, which is the Excellence in Medical Science Awards here, run by Sateria Iramia. And so I thought I'd just give myself a little break and play a video from that.
My research is mainly into atrial fibrillation and the mechanisms of atrial fibrillation. During my PhD, I looked at, in quite some detail during invasive electrophysiology studies, at the atria of patients who had atrial fibrillation and compared them to a control group who didn't have atrial fibrillation. And we got some interesting research well published out of that. But since I've now been doing more clinical work, my interest has gone to clinical trials, really. So we're looking at ways that we can treat atrial fibrillation more effectively.
And just looking at Prash, looking at the sinus pause with the junctional escape there. No patients were harmed in making this video. So we sought to look at our experience, and this was the Waikato and Braemar Hospital experience of the cryoablation. So RF ablation, when I first did it, we did 2 in a day if we were lucky. It was 3 or 4 hours per procedure. We got the cryo machine, and we looked at the first 180 cases we did over with 4 operators, I think it was, and you can see our procedure time coming down as we got familiar with the new equipment. And this was a real revolution for us. We could get more patients treated, and we could do it as effectively as we'd previously done. Coming up to date, we have now 1,000 consecutive cryoablation patients. So we've now got 1-year follow-up. So the patients were ablated between April 2013 and December 2023. 1-year follow-up was completed at the end of last year. These were a mean age of 60 years, procedure time 107 minutes. The majority male, the vast majority paroxysmal rather than persistent, so coming and going rather than there all the time. And the success rates is that patients with no AF and they came off their antiarrhythmic medication, just over half. No AF with those choosing to stay on their antiarrhythmic medication, 15%, giving an overall success rate of 66%, with a really strict definition of just 30 seconds of AF being causal failure. We have better outcomes for paroxysmal than persistent, as is consistent with the international research. No difference in success rate by age. But interestingly, the females had a lower success rate than the males. And this is something we're going to look into with the integrated research module, the Wahine Health module, which is run out of Auckland Hospital with my colleague, Joanna Montgomery. And over the whole 10, 11 years, there were some redo procedures in about 15% of patients after roughly a mean of a year. And of those 176, of those 148 patients, we did 176 ablations, some of them being second redos and even third. So even if we don't get you the first time, we can help you the second and the third time. I think it's important to record our complications. Nobody wants to have a complication, but it's important to record them because we learn from that. So the international data suggests about 3% patients come off the table with a phrenic nerve palsy, which recovers between 1 and 3 months, and we're about that. Unfortunately, we had 6 patients with a stroke or TIA and 7 patients with a tamponade, which were all drained percutaneously, I think. So I think it's important to reflect on your complications. The patients put a lot of trust in us, and we're always striving to be better. And this data was presented by Eddie Kuiman. So he and I have been collecting this research over that decade. He's a nurse who's been working hard, and this is him presenting at APHRS Hong Kong, the best attended meeting I've ever been to, because there was a class 10 typhoon going outside. You weren't allowed to leave the hotel. There was no food outside the hotel, so everybody was at the conference. I wanted to change tack a bit and talk about sudden cardiac arrest. So this is a picture drawn by a child of a patient of mine. You can see they're saying, "I hope you're okay, Daddy. If you're not okay, I will cry," and say, "Daddy, come back, Dad." So in some of these patients, we put an ICD in. This is an ICD, this is a heart beating, this is a ICD, sort of like a pacemaker up in the chest. You can have 1, 2 or 3 leads. This one's going to be a 2-lead one. And these leads sit in the heart. And most of the time it sits there and does nothing. But on occasion, the heart will go into a rapid rhythm, like ventricular tachycardia, and the device is about to go into VT, here we go. That's VT there. The device then sends a series of pulses to try and correct this painlessly. And that may work. And if that works, that's great. But if the patient goes into ventricular fibrillation, which it is about to go now, we then have to shock the patient. And the shocks are painful. Yes, they're saving the patient's lives, but they are painful. And sometimes patients get shocks when they don't need them, which is a disaster. So there are ways to reduce these unnecessary painful shocks. You can delay the treatment. So don't treat the shorter non-sustained stuff, allow time for it to go. Only treat the fast rhythms. Anything less than 185, maybe 200 beats a minute, let that go through to the keeper. Trust the device to discriminate non-life-threatening rhythms from life-threatening rhythms, because the algorithms that do this are really quite good now. And try that non-painful therapy first before delivering an unpleasant shock for the patient. So Matt Webber and I, in 2012, this stemmed out of the fact that every time you put a device in, they'd say, how do you want it programmed? And I'd sort of, we'd have to go through it every time. I said, well, I'm going to set out a set of things, this is how I want it programmed. And we looked at the evidence and came up with the best thing for Waikato. And then Tauranga said, well, we should use that too. We said, cool, you can use that. And then John Skinner said to me, well, if you're going to do a Midland guideline, why don't you do a national one? So we did a national one, and that got published. This came back for like 4 or 5 reviews. It was crazy. It was a very controversial thing. I'm pretty sure it's Harris. And this led to a bit of international attention, and so I was asked, along with others, so Bruce Wilkoff, he was chairing this paper, and he was representing the Heart Rhythm Society of the USA and Canada. Laurent Fauchier was European Heart Rhythm Association, I was APHRS, and Carlos Murillo was the Latin American Heart Rhythm Society. And we put out this expert consensus document. And then 4 years later, we refined it with a focused update, concentrating on some manufacturer-specific guidelines. So instead of saying this is how you should do it generally, we said this is how you should do it exactly, according to which of these 5 manufacturers that you were doing. This is Medtronic's example, could have been any of them. This is how we suggested that you program the pacemaker function for 1, 2 or 3 lead devices. This is how we program the detection, so we know when the patient's getting a nasty arrhythmia. This is what therapy we think you should have, and this is the sort of non-life-threatening rhythm from life-threatening discrimination part of it. And so we put this out there, and it was difficult because people were able to then publish examples of they've programmed their patients like this, and that but for the way they programmed it, they might have survived. But we knew that on a population basis, more patients were living with this. It's quite a difficult thing to see things published. I was really grateful for this. This is not my research, this is from Thailand last year. They looked at about 800 ICD patients followed for a couple of years, and they looked at whether they were guideline concordant, that is, programmed how we thought they should be programmed, or non-guideline concordant, depending on whether they had these non-life-threatening rhythms or not. And you can see in blue here, if you were guideline concordant, you had a much less chance of being shocked than if you were red and were non-guideline concordant. So this was independent sort of analysis of what we thought was a good thing to do and sort of justification of that, so that was good to see. Sudden cardiac arrest can be high profile and quite emotional. So this is Christian Eriksen, who is a Danish football player who had a cardiac arrest playing for football for Denmark. And you can see the distress on the faces of his teammates. There's a sense of need for privacy here. There's distress. Some of them can't look, some of them have to look, and it's quite distressing. Fortunately, he was resuscitated and left the field conscious. And this is a high-profile example of what we see here at the hospital on a regular basis. And so my colleague Arthur Vilder from the Netherlands and I put out this expert consensus statement in 2020 on how to investigate patients with sudden cardiac arrest. And so this was the list of authors. As you can see, they're from all over the world. We have paediatricians, we have electrophysiologists, we have pathologists because of the post-mortem side of it. We have clinical geneticists, genetic counsellors, and even a patient representative here. And this is where they came from. And it generated a bit of media here in New Zealand. I don't know why they always photograph me with the echo machine. It's really weird. Some of you are going, you never does echo. You wouldn't know what an echo was if you bumped into it. And we put out these sort of guidelines. So this is an algorithm, I don't expect you to be able to read this, but investigation of sudden cardiac arrest survivors. What we might do for baseline investigations, how we might provoke things to see what was going on, and how we might do genetic evaluation. So the green stuff is things that we think you should really do. The yellow stuff is things we should probably think about. The orange stuff is stuff that you could possibly do as also. The red stuff is things that you shouldn't bother, it's not worth it. don't do it. And so this is a genetic evaluation of a sudden cardiac arrest survivor. So you clinically evaluate the first, see if you've got a suspicion what's going on, to test for that condition only. In a research setting, you might test wider, but no scattergun approach, please. And so after doing this award, this research, the Kudos Awards contacted me and wanted to do a 10-year retrospective of previous winners. So again, a little break for me. And in 2020, I led an international document which was about investigating patients who'd had unexplained cardiac arrest. And we see this in the hospital. We have people who are otherwise well and they have cardiac arrest, and many of those may have a heritable condition. So what we hope to do is, either by clinical testing or now by genetic testing, figure out why those people have had a cardiac arrest. And if we find that out, we can help them, prevent them from having another cardiac arrest. Not only that, we can help their family members from having the same fate. So we were able to put this document out there as international best practice. And again, my hope is these patients who are previously going undiagnosed will now become diagnosed, not just in Hamilton, not even in New Zealand, but around the world. So that brings me to cardiac inherited disease, which is another area of research that I've been really interested in. So these are heart conditions that are inherited from our parents, and they're often associated with causing sudden cardiac death. And so we make these family trees. You can see the affected individuals here, those that have gene positive, those that are deceased. And we try and, if we get a genetic diagnosis, we try and track this gene, sort of cascade testing through the different generations to try and figure out if we can help people. So we managed to publish this 5 years ago, about 800 or 900 patients with cardiac inherited disease, some of whom, about 200 or so, presented with cardiac arrest. We were able to figure out through investigation what diagnoses they had. We could segregate those diagnoses out by their age group, depending, which was most common, and the relative malignancy of each of these cardiac inherited diseases, which were the worst ones to have and whereabouts in life they affected you. So I want to talk about a different sort of research now. So this is work I'm doing with Professor Julian Payton, who you've just met. So respiratory sinus arrhythmia. We all have respiratory sinus arrhythmia. When we breathe in, our heart rate goes up. When we breathe out, our heart rate slows down. And children especially have this respiratory sinus arrhythmia. It's long been known about back in the 18th century, even 100 years ago, relationship between respiration and pulse rate. And even archers and shooters know to release their arrow at the end of expiration when their heartbeats have the longest time between them. And assassins. Janice pointed out, and assassins. So Julian and his colleagues, Rohit, who's here, have come up with this chronic heart failure model of a sheep. Now, patients in heart failure have even less respiratory sinus arrhythmia. Turns out that sheep also lose their respiratory sinus arrhythmia in heart failure. And we have this model where we have the sheep having atrial pacing and a diaphragmatic electrode giving electromyograms, so we can tell when the sheep's breathing in and when the sheep's breathing out. When it breathes in, the heart rate goes up. When it breathes out, the heart rate slows down. So this is what happens. We have a monotonic group, so they're just pacing at the same rate all the time, and the respiratory sinus arrhythmia varying with respiration. You can see the difference in heart rate depending on all these things. And so what Rohit and his colleagues have done is have a run-in period. You can see the green group eventually get respiratory sinus arrhythmia pacing, and the red group do not. They get metronomic pacing just at the same rate the whole time. For the first week, everything's the same. You turn on the pacing, and the respiratory sinus arrhythmia cardiac output climbs, and it climbs by more than a litre a minute. So ultimately, at the end of 4 weeks, it's an increase in 23% of cardiac output, and that's a huge amount. If you turn off the pacing, it regresses to where it came from over about 7 days or so. Not only that, the ejection fraction improves. That's the amount of blood leaving the heart with each beat. That gets better. And it reduces the apnea, or the breath holds, that tends to happen in these sheep and in patients with heart failure. So, from animals to humans. This is the RSA PACE trial, a first-in-human clinical trial that we enrolled the first patient in the world in last year. We took patients with coronary bypass grafting only, with ejection fractions less than 45%. And after their surgery, we take input from the nasal cannula, the oxygen that they're getting, and that will tell us that's able to tell us whether they're breathing in or breathing out. And we can use that data through this box, this neuron here, which modulates the pacing output through the external pacemaker. The external pacemaker is connected to the atrial leads, which every patient with cardiac surgery comes to the ward with. So we're taking advantage of these atrial leads and using this to see if we can help them. So we're randomising these patients to either monotonic pacing, so that's their own heart rate plus an extra 10 beats, so we can make sure we're capturing, or respiratory sinus arrhythmia pacing. That's their own heart rate plus 10 beats, plus or minus 6 when they're breathing out, and add 6 when they're breathing in. And we're aiming to get daily cardiac outputs during pacing, after discharge, some biomarkers, some echoes and such like. There's a huge amount of technology that's gone into this. There's been a lot of things that have developed, a lot of investment in this. And this is the graphic user interface that we use. We can set these respiratory sinus arrhythmia pacing, we can stop it, we can start it, we can see what respiratory signal we're getting, and ultimately we can see how much of respiratory sinus arrhythmia we are delivering. We enrolled the first patient in Waikato. We have enrolled patients in Cardiff and Prash. You're about to enrol some patients in Adelaide, hopefully in the next week or two, I'm hoping. So again, collaboration around the world. We've had other technological things. This is a first in human experience with a re-sterilisable electrophysiology catheter. You may know that at the end of electrophysiology catheter study, all those catheters go in the bin. This is a reusable one up to 10 times, comes with its own little kit that you can clean it in, and we published this in the Asia Pacific Heart Rhythm Society. We also did this temporary pacing wire. This was able to, it was a temporary wire with active fixation. And what we did, we took 25 subjects, so this is Sanjeevan Pasupati and I here at Waikato, and Nigel Lever and Mark Webster in Auckland. So 4 operators at 2 sites, enrolled 25 subjects, safety endpoints met, technical feasibility mostly met, and very good pacing thresholds at the end of it. And this is a little video just to give me another break of this catheter. So actually there's no sound, so I don't get a break. So it goes into the vein in the groin. You inflate this little sort of balloon on the end of it with saline. It acts like a sail. It takes the catheter all the way up into the heart, whereupon you deflate the balloon and manipulate this catheter under X-ray into the right ventricle where you want it. It's got sort of the soft little tip on it, which is atraumatic, and you nestle it down in the bottom of the right ventricle. And then you orientate it using this radio-opaque marker, which you look at on X-ray to make sure that the tines, which are about to fixate the thing, are pointing in the right direction. You inflate the balloon so it's pushing against the septum, and then you deploy these sharp tines. You want them to go into the middle of the heart, not to the edge of the heart, because you don't really want to perforate. So these little guys come out here as you rotate this mechanism, and then once that's there, you deflate the balloon, and you can pace the heart as long as you need to. And these patients can actually mobilise with this temporary system in them, which is very useful after structural heart things. And then when you're finished with it, you simply retract those little tines and you can pull it out without X-ray. So that was another example of technology. I used it first in a trusting patient here who let me do it. And I don't exaggerate, having these patients trust us with this is really an honour. Warwick mentioned the other part of professorship is service and leadership. Involved in the Cardiac Society of Australia and New Zealand, whose aim is to promote good fellowship amongst those with an interest in the practice of cardiovascular medicine, allied areas, and even surgeons. Trying to catch Zach's eye there, yeah, got him. I was a chair of Heart Rhythm New Zealand, so we represented the EP and pacing workforce group here with my co-chair Paula Jones. I've been a member of the wider Cardiac Society Scientific Committee, the one in Australia and New Zealand. Dr. Mayana Lund and I, she's from Middlemore Hospital, she convened this meeting with me as the program director in Gold Coast. So this is a great meeting, 2022, first meeting after COVID. It was organised by New Zealand, supposed to be in New Zealand, but of course we can't have it in New Zealand because we don't have the right size convention centre, so I was on the Gold Coast. I then became chair of the scientific committee in 2022, and the first New Zealander, in fact, to chair that committee. I'm now the chair of the New Zealand division of Cardiac Society. Started in June, and I've got 15 months to run of that. And I guess one of my roles in that is to advocate for patients and advocate for cardiovascular workforce people. So this was last year. I was on a little bit of media talking about health targets and how we could improve them. And just last week was on TVNZ Breakfast talking about the 15,000 patients, well, let's be honest, it's conservative, right? The 20,000 patients waiting for heart scans. And as a result of this media, today, 2 of my colleagues have met with the health minister in Wellington to discuss this issue. So, it actually does create some traction. I also work for the Asia Pacific Heart Rhythm Society. So I've been a board member there since its inception in 2008 and chaired their Fellowship and Clinical Documents Committee for a time. and I'm now an executive board member. And as the chair of the China Scientific Program Committee, one of my roles is to oversee the annual scientific meeting, which happens around about October each year. So last year it was in Sydney. Prash was the convener. Rather odd situation that I was overseeing Prash doing something. He was giving me jobs to do something. So I was sort of overseeing him, was overseeing me. So it was very Russian dolls. The other job is to co-organise the summit, which is held in March each year. So this is the executive board meeting at the summit, which was held in Kuala Lumpur in February. And next year, the APHS summit is going to be in Auckland. So we're hosting that here at the end of February, beginning of March next year in the International Convention Centre in Auckland, which they promised me is going to be open at the beginning of February. Might be around at your house, Julian. Right. So. The APHRS does also expert consensus statements. So we did this in partnership with those other societies, Heart Rhythm, European Heart, Latin America. So this was my friend Young-Hoon Kim. We put out this statement on 3D mapping systems, which was the first of these statements that APHRS ever put out as the senior author. Do you remember the 193-point map that I showed you earlier in the piece? This is now a 10,000-point map of a endocardial reentrant VT circuit in exquisite detail. Right, so things have come a huge way from where we started, and this consensus statement was really just about pointing out ways we could use this. There's an American Heart Rhythm Society, which I've been on their Clinical and Scientific Documents Committee, their Communications Committee, and now on their Global Affairs Committee. One of the honours that I had with Heart Rhythm 2019 was they had the 40th annual meeting. They have the plenary session, the one at the beginning in the big theatre. So that was hosted by Guy Raz from NPR. And they had this sort of past, present and future thing. So there were past presidents, there were current presidents, and then they got Usha Tedrow from Harvard and I on the stage to talk about the future of electrophysiology. So that was a real honour and good fun to be involved in that before COVID. At Heart Rhythm Society, they have these late-breaking clinical trials with the very cutting-edge researchers presented, and this is, in New Orleans a couple of years ago, being invited to be a commentator on one of the late-breaking clinical trials. This is going to happen again later this month. I'm going to San Diego, invited to be a commentator on one of the new trials that's coming out of there. So again, sort of representing research from around the world. Other things that professors do, they write textbook chapters. This is, some of you use UpToDate, I'm sure you do. And so you may not know that I'm the author of Optimal Programming for ICDs, again. And so that's an honour to be asked there. And they also pay a royalty, who knew? And also in the European Society textbook of Cardiovascular Medicine. And thanks, Julian, for pointing out the publications. I'm now going to go through each of those publications. No, it's all right. Teaching, postgraduate teaching, honours student, sitting at the back, PhD students from both University of Adelaide and University of Auckland with Zichao. Currently, master's students, James and Xander, and PhD students are currently with Zichao co-supervising in Auckland. So it's really exciting to be, these guys have got the time to do detailed research that you can supervise and publish and get out there. There's also undergraduate teaching. We get the fourth year specialty medicine students, Warwick pointed out, we have them coming through here. We have specialty medicine students spending 3 weeks at a time on cardiology, and we have final year training interns who I'm responsible for that group, and they come, and it's great to be able to prepare them for their working career, which is happening just a year later. I guess this is the bit I'm sort of proudest of, really, is the super specialty training. So all these people that have come here, and you'll recognise some of these names, they came here as cardiologists. They decided to do additional training to become an electrophysiologist. So Matt was the first one, he's now in Wellington. You can see there's three names here, Janice, Daniel and Ali. They came here to train, and I'm really delighted to say they are now my colleagues. So we've grown our own, we've trained them, and they've decided to come back. It wasn't so bad, and they're working with us. And it's great. And look, we've got Abby here at the moment. He's going to probably go home to Delhi via his next fellowship in Sydney, and we hope to welcome Nisha here from Barcelona later this year. One of the things that I also do is proctoring and speaking. So this is implantation of subcutaneous ICD. So a lot of the research for subcutaneous ICDs was done in New Zealand, and I did the first 6 implants in Asia, 3 hospitals, 2 each day, in 3 hospitals in Hong Kong in 2014, and then went to Royal Prince Alfred Hospital in Sydney to proctor there. So this is me showing the Australians how to do this. This is a photo that I came back with. Sorry, trigger warning. This, I think Liam was 8, and I brought this photo home, and I think He thought that I got paid to stab people with a knitting needle for a living. And I put this in my talk, like a week or so ago, and actually we just did one of these like this afternoon. So it's Proctor and Daniel, who's the second one of these. So it's all ongoing to learn how to impart knowledge to people. We've held interventional cardiac resynchronization therapy here. Seth Worley came from America in 2017, then we hosted some Australian doctors in 2019 learning how to do this stuff. And then Julian's already mentioned the invitations to give talks. Funding in medical research is a scarce resource. We applied, so Julian and Anna, who's here, led us to, and I was one of the clinical leads, to apply to the Tertiary Education Commission for a Centre of Research Excellence. And there's only a very few of these, and some of them are in astronomy and, economics and, physics. And we were successful in 2021 of getting $40 million from the government. And then we had to decide how to give that away. So Professor Joanna Montgomery and I were the inaugural co-chairs of the funding panel. As Joanna used to say, we put the fun in funding. And we got to give away money, which is great, to research that we felt was consistent with the aims of the organisation, which was cardiovascular health equity. A lot of research, a lot of time goes into reviewing for papers. I get sent papers all the time. Can you peer review this, please? I get sent things to say, can you help us with this funding panel? So these are New Zealand groups, international groups. The clinical trials unit here at Waikato, I don't know, some of you may not know, but it's a big organisation. There's a $800,000 budget per year running through the clinical trials organisation. So this takes a bit of time to help these organisations send the money where it's best used. And then of the money that we applied for, that $40 million, I got to apply for some myself. And so Polona, who's also here in the audience, is leading us, herding sheep, to get this Our Heart, Our Genes, Our Story funded. So we got $1.5 million to look at inherited heart diseases in Māori and Pacific Island patients. So some of you probably don't know that if you're of European ancestry, the chances of you getting a genetic diagnosis for your inherited heart disease is twice what it is for Māori and Pacific Island patients. The reason being, the databases for genetic heart disease are European and American, and there are really no people of Polynesian ancestry in these databases. So we're taking what we call a database agnostic approach to these patients who have not been given a genetic diagnosis by traditional means, and we've already been successful in finding genes that are causing heart disease in Māori and Pacific Island patients that were previously not known about. So, what now for the professor? Warwick, I thought I'd just let myself go. It's all got to be downhill from here. That extra $7.33 a week I get, trying to choose how to spend that's been difficult. But probably not, as Julian's alluded to, it's probably going to be onwards and upwards. So I need to complete my time as the Cardiac Society Chair. A lot of things I want to advocate for our workforce, for our patients. We're going to host this APHRS Summit in 2026, and in a way, it kind of serves as an audition for a meeting maybe in 2030, 2031, where we have about 3,000 people attending. I'm on the APHRS leadership track, so that will probably continue, and I'll be continuing to research sudden cardiac arrest, AF substrate, respiratory sinus arrhythmia pacing, which I'm really excited about, and the inherited heart disease, which I've alluded to. I'm going to be promoting, recruiting and training New Zealand EPs and probably EPs for other countries as well, and mentoring students who are coming through the Waikato Clinical School, University of Auckland, and teaching them. I'd like to thank you to my university colleagues. You've come down. It's great to see you. It's great to be supported by you. It's great to do research with you and to teach. Also the research collaborators in New Zealand, abroad, around the world. I'd really like to thank my clinical colleagues at the 4 places that I work, particularly my EP colleagues, both the cardiologists and the physiologists, who we work really closely with and depend upon a lot for the sort of work that we do. I want to thank the wider cardiology department, but not just the cardiology department, the cardiothoracic surgeons, the anaesthetists, and the wider hospital, because we interact with all of you, and it's great to have your support. I really want to say thanks to the patients, because these patients put a lot of trust in us, and the patients put a lot of trust in us to treat them, and also even more trust when we're trialling things for the first time that haven't been trialled in humans before. So I'm really grateful for the trust that patients put in us. Really grateful for the students, because they provide inspiration. You love teaching them. They're always sort of enthusiastic. They're not as cynical as we are, yet. And so, but that always provides some motivation to do the job. I really want to single out, because I don't want to talk about people individually because I forget people, but I want to thank Praise Standards for mentorship. The very fact that he's here speaks volumes and has come literally around the world, to arrive 2 minutes before the thing was ready to go. I really want to thank him for his mentorship and the things that he's done. And last, I'd like to thank my family, mum and dad. They're here. Thanks for supporting me. I want to thank my siblings, Clark, Dinah and Carol, who've also been very supportive. I want to thank my family, my wife Rachel, who's sitting here. I want to thank our kids, Liam and Isabel, and Brooke and Kate, for their love and support. Thank you.
So ladies and gentlemen, Martin, thank you for having me here. It's really a profound privilege to be able to come here and really close this amazing journey and event and an inspirational inaugural lecture that you've just delivered, Martin. So Martin's alluded to the fact that it's now 20 years since he joined my lab as an EP fellow and a PhD candidate. He was my very first PhD candidate, so it's kind of a special time. And even from those early days, it's kind of obvious that Martin was going to be amazing in his career. He, not just as a clinician, but in his research, but also in terms of his leadership skills, which you've kind of seen here on display. Few of you would know that I tried very hard to keep Martin in Adelaide. He turned me down to come here. It's also the year that we published our first paper together, and we've continued to collaborate over this 20-year period, despite the fact he's not been in my department, and that's, I think, a credit to our relationship. Today really marks an extraordinary journey that has culminated in him being appointed as a full professor at the university, something that he was destined to reach. Now, Martin's talked about some of his contributions, and I'd kind of like to give an outsider's view of this because he's been very timid in some of what he has said in this. His contribution to cardiac electrophysiology has already been immense in our field. He's been steady and determined in what he applies to various societies. He's talked about the Cardiac Society of New Zealand, the Cardiac Society of Australia and New Zealand, and also the Asia Pacific Heart Rhythm Society. And he's made a significant mark on each of those societies over the years. And I have no doubt that in the next few years, we're going to see him take on leadership roles in those societies in a way that he's going to be able to change disease management around the globe, and also in terms of nurturing the next generation of electrophysiologists that are going to come through. So this is a pivotal role that Martin's going to be taking on. While it's impossible to recognise all of his achievements, and he's talked about some of them, he's alluded to the fact that he was able to herd a group of type A personalities in a room from different fields in order to come up with an international consensus document that really has set the standard on what the world should be doing for a variety of conditions. This has really been for the benefit of patients, for their families, and it's a real impact in terms of what someone needs to be able to do in that situation. That's a definite leadership skill. It shows wisdom, it shows the impact he has on the field. He's alluded and he's thanked his family. Look, this journey is never possible without family backing. And Rachel, yourself and the extended family, what you have sacrificed, the times that he's not been there, have been crucial in his journey to achieve this. One of the things that clinical academics don't get recognised for is the things that are unseen. There are so many things that are unseen. There are late nights, there are missed family opportunities, there are struggles on every paper, every student, every grant. There's even struggles as we deal with patients while trying to balance the research. This is something that everyone doesn't see, but we're all appreciative that all our colleagues are actually supportive and have belief in what we're doing to be able to enable us to achieve this, and none more so than what Martin's able to achieve here. So as I stand here today, kind of reflecting on what Martin has done, it's not just as a mentor, but also as a proud colleague and a collaborator long term. He's become a close friend, a confidant that we discuss many things with over the years, as a first PhD student often is. So I'm touched by that. Watching him grow from being a dedicated student to now what is a distinguished professor position is really a position of immense privilege for me. But the measure of an academic career is not just in the output of work, it's also the impact you have on people's lives and on the next generation. And Martin's well on track to be making those changes and having a huge impact already in Waikato and the rest of the world. And what we see is that in the next few years we will see a lot more, and this is an upward trajectory. It's a staircase, but it is an upward trajectory. Martin, congratulations on really a well-earned recognition on this day, and I look forward to seeing what the journey brings for you in the next few years. Here's to the next chapter in your journey. Thanks for having me.
Martin, what an outstanding lecture, what an outstanding career to date. I want to honour your whānau tonight who have no doubt put you in this position. I want to acknowledge the patients who have trusted you, as you mentioned, and I want to thank your clinical colleagues who have supported you into this position. It is truly an honour to welcome you to the professoriate, and as a marker of this occasion, I don't want people to miss the fact that you were introduced by two giants of academia, Julian Payton and Prash Sanders. This is a mark of the distinction in which you are held. I'd like to invite you forward. We have a small token to remember the occasion.